Okay, thanks very much, everybody. Welcome back. I'm sure we've had a lot of interesting discussions in different groups this afternoon, but now welcome back to the plenary session, and a huge pleasure to welcome Dr. Fiona Godlee, Editor-in-Chief of the British Medical Journal. We saved the best till last, I think. Just a few words of introduction. Fiona trained at Cambridge University and then became a general physician and is a fellow of the Royal College of Physicians. But since 1990, so for 25 years, she's been writing in the medical literature, including a range of issues for the British Medical Journal. Interests are very wide and varied, include the impact of environmental degradation on health, future of the World Health Organization, ethics of academic publication, and the problems of editorial peer review, issues that we've encountered, I'm sure, once or twice in our career. But in 1994, she went to Harvard as a Harkness Fellow and started looking at the issues, the problems, the ways that we can try to bridge the gap between medical research and practice. And then on coming back to the UK, she led the development of BMJ clinical evidence, bringing the best available evidence to a range of clinicians, and is now available to over 1 million clinicians in 9 languages, so tremendous impact. In 2000, she was part of the group that was instrumental in setting up Biomed Central, which is obviously well known to those of us publishing in these areas. She's also been president of the World Association of Medical Editors and chair of the Committee on Publication Ethics. She's on the advisory board of the Nordic Cochrane Centre, a huge range of activities. And then, as we know, for the last 10 years, editor-in-chief at the British Medical Journal. And as editor, she's been instrumental in supporting the campaign that we've heard a little bit about today, which is around overdiagnosis and overtesting. Following conferences in North America and Oxford, there's quite a lot of interest and a campaign going to think about the issues of overdiagnosis. What happens when a diagnosis, which appears to be medically correct, is made and leads to a treatment, but which does not lead to net benefit for the patient? And by the way, does cost a lot of money in the process. And that situation is unsustainable in the short term, never mind the long term. So we've heard about prudent healthcare, obviously today. These issues really come together, and it's a core part of our work now going forward. So really, there is no one better placed to talk to us about how these issues should impact our research, and then also how we should take that forward to outcomes and impact of our research. By outcomes, we mean the sort of academic outputs and journal publications and dissemination through conferences, but increasingly now, and quite rightly, driven by the Research Excellence Framework, we're thinking more about how does that translate out into practice? How does it transfer into routine practice? And what's the impact in terms of benefit for patients and the public? And we need to be thinking about that. And again, Fiona is extremely well placed to offer us her comments and experience and guidance for taking this work forward. So thank you very much for coming, and we look forward to your thoughts.
Thank you very much indeed, Adrian. Well, it's an enormous pleasure to be here, and interesting hearing Adrian say I have a wide and varied range of interests. I feel I get more and more obsessed with the smaller and smaller focus as over the years you keep on banging on about the same stuff. And well, I think there is change and lots of room for optimism. And this launch today of Prime in Wales, I think, is an enormous reason to be optimistic that you've got the funding, that you've got the collaborative support. You have your minister, I gather, earlier today, and chief medical officer, and a very integrated approach to the challenges you face, which I think would be nice to say that was also happening in England, but I'm afraid I can't say that. It does seem to me that we are at a time of enormous challenge and potentially, therefore, a great opportunity. We've got very limited resources. We've got this ever-increasing demand for healthcare. And in times like this, I think it's possible to turn to tradition, comfortable tradition. It's possible to become very ideologically driven, which does happen. Tribalism is a big threat. I think people protecting their own territory, throwing blame around, or panic, indeed, which I think is what's happening to some extent in England at the moment, or, as I hope will happen, and Prime and other groups like it will help us to base our response on the evidence and to really try to have a much more logical and rational approach to a better future. I was asked to talk about world-class research and delivering that, and I think my talk may ramble around a number of issues that come down to an attempt to improve the evidence base for clinical practice and health services. And I wanted to start by focusing on 3 rather good papers that I've found very helpful in the last few years. I think I'm going to change the slide with... So the first is a paper you may have seen published about quite a long time ago now, 2006, by Peter Rothwell in Oxford, and it led us at the BMJ to talk about the Rothwell agenda, by which we meant a shift slightly away from a focus on clinical trials as the be-all and end-all of the research base, the evidence base. And what Peter was saying in this editorial was that there was this very neglected field of clinical research, by which he doesn't mean trials as such, but basic observational research necessary for effective clinical practice. And he talks about the types of questions that aren't being addressed enough in research, about the reliability of clinical diagnosis or about prognosis. How certain can you be about the diagnosis, doctor? That kind of question that a patient might ask. What are the risks of a poor outcome over the next few weeks, months, or years? How do my particular characteristics influence the likely outcome? The trials showed that this treatment is likely to do more good than harm on average, but are the risks worth taking in my case? So that's a kind of collection of questions that he felt back in 2006 were not being properly addressed. And he gives various examples. So the lack of basic data on diagnosis or prognosis is the main barrier to effective treatment in routine care. He gives a list of reasons as to why academia is failing to deliver on these matters. And some of them are listed there: too few practicing clinicians in decision-making roles, and hopefully Prime and other initiatives will change that. Bureaucratization, and I think the underestimation of the immediate improvements in outcomes such clinical research can deliver. So there's a tendency to kind of feel a bit fatalistic about what we can do. He says, I think very eloquently, if the research necessary to improve diagnosis and prognostication is easy and relatively cheap to do, which it usually is, then failure to gather the necessary data is indefensible. It would, for example, be inexcusable for the airline industry not to bother studying the diagnostic and prognostic reliability of routine aircraft safety inspections, yet we fail to apply the same standards in medicine. And at the end, he says, greatest of these is the tendency for... Sorry, this is about potential pitfalls. Greatest of these is the tendency for clinical research to be defined too narrowly as being only bench-to-bedside translational research, large-scale epidemiology, and pharmaceutical trials, with the lowest hanging fruit, observational research, necessary for effective clinical practice, continuing to be neglected. So when that article came out, we took that very much to heart at the BMJ, and we began looking out for observational studies where that really could be applied in practice, such as red flags for cancer diagnosis or similar studies as that. And I think over the years we have really tried to make sure that we publish as many of those good ones that come our way. The other article I wanted to raise here was this very good piece by Ian Chalmers and Paul Glasziou in The Lancet in 2009 on waste in clinical research. And this, again, has been very influential in a lot of people's thinking, and certainly in mine. The authors list these various sources of waste at the different points in the research cycle, if you like. So the fact that the questions are not relevant to clinicians and patients, the appropriate design and methods aren't used, it's not accessible for full publication, and then you end up with an unbiased or unusable report. So at every stage in this process, and they document with much more detail what the problems are there, we get waste and therefore the wrong answers possibly to the wrong questions. And then the third one, which again you may have seen, is a rather good article by Trish Greenhalgh and colleagues called Evidence-Based Medicine in Crisis. And again, they summarise what the key issues are around the problem with evidence-based medicine, which began with this wonderful flurry of enthusiasm and even a religious fervour, although it was heavily criticised even at the time for the risk that it was going to be focused too much on trials and not enough on expert and patient experience. So one of the issues they talk about is vested interest, and I will try and address that. It's one of the obsessions for me, how the research agenda has been hijacked, if you like, by vested interest and failure to report studies as well. And then the volume of evidence, especially clinical guidelines, has become unmanageable. So although it's a very positive thing, we've got all this evidence, it actually becomes very hard for clinicians and patients to navigate. Marginal, small changes in statistical significance being discussed at great length when in fact their relevance to clinical practice is quite small. And then we've got the problem of rules-driven care and producing management that's driven by those rather than by patient need. And evidence-based guidelines often map poorly onto complex multimorbidity. This is an issue which I think is of huge importance to a group like Prime. We know that the figure of 90% of clinical interaction has been quoted as what happens in primary care. And Adrian and I were talking earlier about the fact that only 7% of the research base is actually relevant directly to that population group. So this mismatch between where the research is done and where the problem or the burden of medical interaction is a real issue. And of course that 7% of relevant trials, relevant research goes into clinical guidelines, but so too does the 93% of less relevant research. And I think that mismatch is something that is a real challenge. So taking those three articles together, there are only some amongst many articles that have looked at the problem we currently face, which is that the evidence base itself is not really serving us as well as it should. These are some of the solutions that they and I would list. We need a research agenda that addresses questions that matter to patients and the public. We need research into non-drug interventions. When you talk to patients, all the evidence shows that patients don't necessarily want a drug. They want to discuss other options. But if those other options aren't available, or if the time in the consultation isn't there for them to be discussed, the tendency is to opt for a drug. Basic clinical research and observational studies, the low-hanging fruit. That's the Rothwell agenda. Trish Greenhalgh and colleagues talk about the broader, more imaginative research being needed, patient experience, doctor-patient interaction, understanding much more about what drives those things and makes for a good interaction, and one that will come out with the best outcome for the patient. More post-marketing research in day-to-day hospital and primary care settings, which of course I think Prime would be a great driver of, so that we're not just taking these short randomized trials, 8-week trials, that sort of thing, and actually looking at what the longer term and the real life experience of treatment is. Looking at outcomes that matter to patients. Time and again, if you ask patients what they want, the surrogate outcomes or the very specific technical outcomes that research tends to favour are not the ones that really interest them. Clear evidence that the research is necessary in the first place. This is a big part of the Ian Chalmers and Paul Glasio article, to say that before a research study is actually undertaken, we really need to have proper systematic review, not only to check whether the answer has already exists in the literature, which it may well do, but also to learn from the quality of the evidence that's there to try and build a better design rather than making the same mistakes as have been made in the past. Proper study design analysis, that seems obvious. Independent research, and I will talk a bit more about this, seems to me a crucial thing that we've got to push for. And again, funding from government, as you're benefiting from, is a huge help, and the more we can see of that, mechanisms to try to establish funding streams that maybe come through pharmaceutical industry, device industry, but where they aren't in control of the way in which those sums are dispersed, I think is going to be the only future I can see for really good quality, independent, more unbiased research. and independent third-party scrutiny of data, and I'll talk briefly about our paroxetine experience, which we published last week, which is a Bangor success from David Healy and colleagues about the paroxetine trial. Properly reported, all sorts of reporting guidance, full transparency, and open access to the full paper and protocol and data. And I gather that the next ref for research will require open access. The BMJ is an open access journal, so we're all for that. So what is the BMJ doing? This is our peer review process. We get research submitted, about 4,000 to 5,000 articles a year, of which somewhere between 4 and 7% end up being published, and that's the way in which that happens. We think it's a marvellous process, but most people think it's a bit more like this and feel very upset when they get their rejection letters. But we have a whole host of other checks and balances which we over the years have built up to try to ensure that what we're doing is the best thing for patients. We want research that will be really relevant to clinical practice or policy making, and pretty much everything is double, triple, quadruple checked, and lots of shared decision making amongst the editors. So this is today's research page, just to give you a quick snapshot of some of the research we're publishing. Some of it's very methodological, looking at how to improve the quality of studies. This Restoring Study 329 I'll talk about in a minute, and then some dietary public health type research. So there's not much overtly clinical there, but we do absolutely seek out and publish, hopefully, the best clinical research we can find. The Restoring Invisible and Abandoned Trials is the RIOT initiative, which, as I say, last week we published a reanalysis of a now infamous study that was published 14 years ago on the antidepressant paroxetine. It was a GSK-funded study in about nearly 300 adolescents who were with severe depression, serious depression. And at the time, the findings of the trial seemed to suggest that the drug was effective and safe. And there were immediate concerns about that from the FDA and others. But those concerns didn't seem to have the effect you might have hoped, in that the authors didn't respond to criticism, the institutions failed to correct the record, and the journal has refused to retract the paper despite serious concerns about it being ghostwritten and the adverse effects of this drug, including serious suicidal ideation and self-harm, being underplayed. So authors, including David Healy at Bangor, have reanalyzed the data based on data available through legal action that took place in the States, and their reanalysis, which has been a labour of love over quite a few years, which, again, we did an enormous amount of peer review and checking on, has resulted in this reanalysis. And the very important aspect of the reanalysis is that the data themselves are now available. So if the reanalysis is disagreed with by other people, which inevitably it will be, that can be addressed through looking at the data rather than arguing through a black box. This initiative, RIOT, I do consider to be important, and the BMJ has been sort of at its inception. And the idea is that where data are available, that we will encourage other authors, if the original authors aren't willing to do the reanalysis of a trial that's either been abandoned or is disputed, we will encourage others to do that, and we will publish the results. So it's a kind of effort to deal with the legacy of poor research that's taken place in the past, in addition to the other activities we're involved in, which is to try to improve research in the future. I should say that we also win prizes, and this is a prize that we've just been awarded, the Ig Nobel Prize. This was a Christmas BMJ paper, which was about the fact that prognostically, if you go over speed bumps and you get pain, then you're more likely to have acute appendicitis. So this was, I think, people who were driving to hospital and had pain when they went over speed bumps. So there we go. This is we're going to go and get this award at a ceremony sometime soon, so that'll be a great event. Just a quick slide. I don't know what you can gather from this slide, except that it's meant to show you that we care about study design. This is a bit of data that we look at after the event of studies we've published to see accesses to research papers. Accesses do broadly convert into citations. There is definitely a correlation between the number of times a paper is accessed and the number of times it's cited. So it's a kind of proxy measure, and you can't read that, but the big red line is systematic reviews. And so we do find that people generally do those are ones that people want to read, as are randomized trials. We have found, sadly, for we're encouraged, and we would like to publish more qualitative research, but we find that they're not highly accessed and not highly cited. And so we might argue, well, we're not really serving our audience by publishing those, but it is part of the wider agenda to make sure we do have stuff on patient experience. We haven't really found a way around that at the moment. So the other thing the BMJ is doing is campaigning, and this is a series of special issues we've done on missing data and open data, trying to push for greater transparency, knowing as we do that a great deal of evidence data are hidden, not published in the first place, or published in such a way that the data are distorted to the extent that a large proportion of treatments today are exaggerated in their benefits and the harms are underplayed. And that's a theme that goes right across the medical literature: positive publication bias, emphasizing benefit and minimizing harm. And the only answer that we can see is greater transparency, but also, as I've said, independent research, so that conflicts of interest are not such a big part of it. Another campaign, in addition to the open data campaign, is partnering with patients. It absolutely seems to us essential that any future research agenda is driven by patients' needs, and that the research is done with patients involved from the outset. We have a number of threads to this campaign, which is advocacy of the sort that you can see there. Also trying to get, as part of doctors' education, an understanding of how patients are thinking about their illness. And we have been the first journal ever to receive this kite mark of approval called Patients Included, which is to show that we are actually trying to be the change that we want to see in the world, rather than simply just talking a lot about it. So we have a patient panel. Simon Denegri, who you heard earlier today, is on the patient panel. We have patient peer review of our research articles. We ask authors now to say in what way patients were involved in the research. And our plan is that initially asking is the first step, and then once we've got over that step, we will require it, so that I can see in a year or two's time it will become an essential part that they will have been involved, and if they haven't been involved from the outset, we won't want to publish their papers. So that's, I think, that's in my experience how we have helped, or we think we helped to push the agenda, is first ask the question, expose the extent to which it's happening or not. Because for some research papers, it just has to say patients were not involved, and we publish that, and that begins to make people think differently, we hope. And then to require it is the other thing. We're also doing co-creation with patients of our educational material, so authors increasingly encourage just not clinicians, but to have a patient on board as an author, and to say again how patients were included in the creation of a piece of educational work. That's just, there's quite a long patient strategy, but that's just two issues within it. And then, of course, as Adrian said, we have a campaign around too much medicine. And the reason I mention that in this context of research is because it does seem to be an enormous part of the research agenda. It has to be to look at how we can deal with this limited resource, increasing demand, and harm and costs that are caused when people think that more medicine is better medicine, when in fact, increasingly we are finding over the whole range of medical specialties and medical treatments that actually more medicine is not always better medicine. Acknowledging, of course, that there is also undertreatment and underdiagnosis, but we feel that our job is to point out this slightly countercultural feeling that overdiagnosis and overtreatment is a sign that medicine is rather overreaching itself, has gone beyond where it should in terms of medicalizing normal life and offering treatments when other approaches might be equally successful. And just briefly to give you a quick sense of what those articles we've published have done, we've had quite a structured approach to them. We've tried to, this is one on mild hypertension in people at low risk, we've set the clinical context. talked about why a diagnostic change might have increased the number of people who fall into this new category of mild hypertension, the rationale for the change, and importantly, this leap of faith, which I think is a key part of these articles. So the leap of faith in the case of mild hypertension is that lowering threshold blood pressures will lead to increased diagnosis and treatment, which will decrease mortality. And the reason that's a leap of faith is there's no evidence base to support that assumption. And then, of course, once one's extended the diagnostic categories to increase the number of people who fall within this definition of mild hypertension, the prevalence goes up, and we try to explain the evidence that this is a kind of overdiagnosis. Use of a uniform threshold to mark hypertension risk ignores evidence that risk varies by individual and includes many people who will not benefit from drug treatment. And then we talk about the harms of this. Obviously, more people on drugs, more people with the side effects of drugs. There's the cost involved. There's the fact that people are taking tablets, which turns them into patients, and the limitations of the evidence, and then the conclusion. So this structure we found has been very helpful across a very wide range of conditions. Here's one looking at CT pulmonary angiogram for pulmonary embolism. And here you've got a situation where the test is just becoming so accurate that it's identifying smaller and smaller and smaller lesions. We don't know what to do with them. Patients are then told they've got pulmonary emboli, they have to have regular checkups, but actually, are they benefiting? Is their life improved? Do they live longer and better lives? And the evidence suggests that they don't. And time and again, what we're finding with this is that the sort of pathognomonic feature, if you like, of this over-diagnosis, over-treatment thing is that the mortality, this is pulmonary embolism, mortality stays the same as time goes on, but the incidence rises without any improvement in lifespan. That was with CT angiogram, and this happens again. This is thyroid cancer. So again, mortality staying the same, incidence rising, and these are the new and better diagnostic tools being applied, which are identifying smaller and smaller nodules, people having their thyroids removed, people having iodine treatment for life, and having to have regular checkups and the risks involved in the operation to start with. So this is a sort of series of, this is a frequent now finding, I think, when you look at conditions again and again, we're seeing this pattern. Colonoscopy for colorectal polyps, again, increasingly accurate, finding smaller and smaller lesions. Do we remove them? Do we leave them where they are? Does the patient come back and have another colonoscopy a year's time? That whole anxiety. Very, very hard to know what to do in such cases, except to, again, explain to the patient, and also recognizing that when we get better at distinguishing the risky polyps from the non-risky polyps, of course, this equation will change. And we've got that example with the hepatitis C, that screening for hepatitis C, the overdiagnosis campaign says don't do it because there's nothing you can do. And then suddenly new drugs come on stream and suddenly it does become worth doing. So all of this is predicated on the fact that treatment improvement or prognostic improvement will change the equation. But at the moment it seems like finding these polyps, smaller and smaller ones, is not benefiting patients. And chronic kidney disease is another example of expanding definition, where more and more people are caught in the net of the definition. They have regular blood tests and sometimes treatments which they don't benefit from. So why is this a problem? Well, this is Margaret McCartney, who you may know, a marvellous GP, and one of the leading lights of the overdiagnosis, I don't know what we call it, movement. And the RCGP has got a very active group of which Margaret is part. Too much testing of well people and not enough care of the sick worsens health inequalities, drains professionalism, harming both those who need treatment and those who don't. And what's driving it? Well, this is an article which is very much more of on the American side, but it concludes that intolerance of error and a culture of blame drive medical excess. I think that may seem like a more of an American view. But they say many reasons why physicians engage in over-testing and over-treatment are perverse financial incentives, commercial marketing efforts designed to create demand for more testing, diagnosis and treatment, and fear of legal malpractice claims. But intolerance of uncertainty and error may be the most important reason that physicians engage in medical excess. And I'm sure we would all recognise that, both as patients and as doctors, wanting to know with greater certainty what the outcome might be and having to manage that uncertainty. And I think that's an enormous part of the research agenda for a primary care-based research effort, is to try to understand how we can navigate around those levels of uncertainty, because however much more research we do on the clinical front, there will always be, we're never going to get away from those uncertainties. And just most recently, this guidance has come out from NICE about suspected cancer, how to decide when to refer and how to cope with the urgent referrals versus the less urgent. It's a very, very good guideline. People have an enormous sense that a huge amount of research has gone into this guideline. It's been a mammoth task. I don't want you to laugh at the next slide, although most people do, but it's our effort. We have this very good infographicist, Will Stahl-Timmons, who started producing infographics for complicated things. And although this looks very complex, this is his version of a nice guidance. But actually, it is very easy now on this to follow through. And these posters are being distributed now, his poster in the NHS, to follow through the referral pathways for these different suspected cancers. So it's a huge piece of work, absolutely solid and important. But I was very struck, Kevin Barraclough wrote us a rather good piece on the guidance, in which he raised the problem of overdiagnosis and over-treatment. And he says that currently around 11% of patients referred urgently with suspected cancer have the disease. That's 9 urgent referrals for 1 new case of cancer, or 6 investigations before 50% chance of being diagnosed with cancer. That's the current situation. If the new guidance is taken up, which we assume it will be, if all GPs refer at a 3% risk, that's 33 urgent referrals for 1 new case of cancer and 23 investigations for 50% chance of cancer diagnosis. And he makes this rather good point at the end. I've also faced future risks from other cancers. This is him as a patient. Arterial disease, neurodegenerative disease, chronic kidney disease, and so on. One concern is that I will retire from general practice and spend my remaining years in hospital outpatient clinic. And I think that is actually what faces us all. One of the very great papers we published was by Victor Montori about the need for minimally disruptive healthcare, and this idea that patients are going to spend more and more of their time actually engaging with health professionals and health professionals with them, and there just won't be any time for smelling the roses and having a normal life. Iona Heath is another leading light of this overdiagnosis, overtreatment campaign, and her view is that we can blame a toxic combination of vested interest and good intentions. So there are multiple factors here driving this medical excess. Not all of them malign. Sometimes this is patients wanting the best, it's doctors wanting to do the best for their patient, but there are malign influences in terms of vested interest. And to that end, one thing about the way in which research gets into education, I want to just mention, this is our education channel, and we are now doing something which I'm not entirely sure is sensible or feasible, but we're doing it anyway, which is that we have decided that our education content will be written by people who do not have financial conflict of interest. It's extremely hard to do. We are the 2nd or 3rd journal to try it. The New England Journal tried it in 1990 and then abandoned it because it was just... the editor at the time thought it was working fine. The new editor came in and said he didn't think it would continue to work. So they stopped, because there were topics on which they couldn't find experts without conflict of interest. Dermatology and psychiatry were the 2 that rang a bell at the time. And we have long wanted to do it, and then we just have decided to do it. So what this means is that we are, will be topics that we can't cover, and we are going to make that, we're going to say in the journal, we tried to get something on this, but we have so far failed to find someone without conflicts of interest. The risk is, and this is what the New England Journal editor tells me, is that we will end up publishing educational articles which are not as good as the ones that would have been written by the expert with the conflict of interest. I think that's arguable. My view is that we will get a good piece, and it will be better for the fact that it isn't conflicted. And we are studying this. We're doing an evaluation to try to see whether, first of all, whether readers care, which I think actually they may not, I don't know, you can tell me otherwise, or whether the quality of the article is similar or better, or different, and whether the recommendations made are different. So it's a piece of work ongoing. I thought I would just end. This is one example of a recent clinical review which addresses an issue that I know is of huge, what can I say, challenge, opportunity. Everything for primary care is around managing patients with multimorbidity. And we try to present the bottom line. This will be an article without conflict of interest from the authors, but at the end of which we publish, where we can, a list of future research questions relevant to that topic. And we'd really be delighted if you look at any of these and have views on whether we've captured the most important research questions. What we very much hope is that whoever picks up on these research agenda questions will do so in a patient-centred, patient-focused way, with adequate independence, transparency, and all the methodological safeguards that I've talked about. Thank you very much.